Please welcome to the stage Clint Flanagan, MD, founder and CEO, Nextera Healthcare.
As we're moving forward, we are going to have an awesome chat about enterprise direct primary care. While some may have a clinic in Toledo, Ohio, one doc, 500 members, and that's working great. Others have said, gosh, I'd like to maybe get a number of different clinics together, kind of like Dr. Rickner was talking about this morning, to take care of employer groups in Oklahoma. So our next speaker is going to come out and have a little discussion about enterprise DPC.
Please welcome to the stage Mark Tomasulo, DO, CEO, PeakMed. Josh Dunsby, PhD, Client Advocacy and Consultant Relations, One Medical. Moderated by Dave Cameron, MD, Chief Medical Officer, Hint Connect.
So great, thanks for having us here. I'm David Cameron, the Chief Medical Officer at Hint, and I'm pleased to have the honor to have Mark Tomasulo, Josh Dunsby. Now, many of you know these gentlemen here. Mark has been very instrumental in direct primary care, started up his own DPC, grew a large organization called PeakMed, and many of you have started to hear the news that PeakMed just got acquired by One Medical. And so we're going to dive a little bit in that story. Josh, he has had a very interesting story. He's got a background in public policy in Washington, D.C., also in the state of Colorado. He also has been with Mercer as a benefit consultant, and now he is at One Medical most recently, and he is a VP of Client Relations. So excited to have the two of them here. And our topic today is really about scale. How do you start small? Many of us are in small practices. How do you go from one doctor, one provider to the second, to multiple locations? And there's different ways to do that. And so we have really two different opportunities, two different stories that we're going to dive into today. And so we can hear their stories. So first, Mark, tell us a little bit about the PeakMed story. How did you start off solo? How scary was that? And tell us about the progress and the progression.
Yeah, well, I appreciate that. So for me and PeakMed, when I started the company, I was a disgruntled, angry primary care doc, to be quite honest with you, and angry at the system and angry at the process and being a widget in that. And I felt at some point physicians needed to be involved in the business side of healthcare and doing it in a way that was more advantageous for us than anybody else. And so I started down the process of PeakMed saying, you have the option of looking at it and changing kind of a lifestyle practice for myself. Let me go get a couple hundred patients and kind of do that for the next 20 or 30 years. Or we can look at it from the perspective of how do we maybe impact healthcare in a much larger way with some physician leadership that has the ability to maybe change, first off for my small little community circle, and then expand that community circle. And then maybe in this visionary idea that you can change healthcare in a very macro way. That was kind of the hypothesis. That was the start of the practice itself. So I took a little bit of a different approach to PeakMed initially. I knew I was probably going to build a practice that I could never work in. And other physicians were going to have the advantage of working in that type of practice. So I was the doc that had worked for Docs Who Care, doing rural medicine and doing the ER and the ICU, and if I admitted a patient, then I admitted him to myself and I rounded on him the next morning, and we did this to pay the bills for the practice and myself. And in order to look at the business component of primary care and direct primary care and how do we make that maybe successful. And so that was my approach. And I think as the years went along, I started on the consumer side. 100% of the population was consumers, and it very quickly became those consumers had small businesses and they wanted to give a benefit to their employees. And so it then became this employee type of conversation, and those employers got a little bit bigger and maybe they had 50 or 60 employees, and then a consultant or a broker came into the conversation. And so you had to start educating a broker or a consultant on what this thing called direct primary care was and what the value proposition is and why should that person pay additional money even though they're already paying for insurance. And it very quickly became this process that took on a life of its own. And so what started as 100% individuals now sits at about 20% individuals, 80% employers, and it changed how you actually looked at running a company and a business in direct primary care.
Great. Now, Josh, I want you to give a little story about One Medical, but give it through the lens of yourself from your background, from the healthcare consulting side.
Yeah, thanks, David. So I recently joined One Medical and have a role being kind of calling it client advocacy. And it's really to amplify the voice of the employer throughout the organization, which I think gives you, some indication where One Medical is in its own growth strategy. It also started out in a very kind of direct-to-consumer model, and that's still very important to it, the overall business model. But increasingly over time, more and more of the business is coming through direct contracts with employers, our clients. And so that's part of, then my role is to really begin, that's part of our growth strategy, is really to be able to deal with the consultants and brokers, which is part of my background, in a more sophisticated way. And I think, I think for context, in understanding the funding source for healthcare is really important and often kind of gets missed. And we all know that employers pay for more than half the medical spend in the US, but I don't know that everyone always recognizes, like, of that portion of spend, about 2/3 of those folks, of workers, are on self-funded health plans, which means their employer is at financial risk for their health. So you're now dealing with a benefits team that's often managing thousands, millions, billions of dollars in spend, and the role of the consultants and brokers is really to sort of back them up on all of that.
Okay. I had dinner with a direct primary care practice, and one of the questions that they asked me is, how do you talk to brokers? She had an appointment scheduled with a broker, but wasn't quite sure, how that would go. Do you have some suggestions for us in how we approach brokers? What are some of the do's and the don'ts? And that would be for both of you.
Oh, you want me to start the broker conversation? I would say that very quickly in the process of growing the company, you realize, first off, you can't do it by yourself. If you want to scale and you want to grow and you want to get bigger, you have to have help in a lot of different places. And if you want to approach the employer market, you have to do that through brokers and consultants. You can do it to direct to employers, but at the end of the day, a consultant should be involved in that conversation because the employer looks to them as the filter to determine whether this thing makes sense or not. So understanding what's important to the consultant from their lens, what's important from the employer in their lens, while at the same time knowing that there is an underlying agenda, which is we're trying to grow our business. And how do you do that in a very respectful, collaborative way to where you're not taking a position that I hate brokers or I hate consultants, or if the employer just really understood what we were doing, they would do this all day long. So having more of a collaborative approach to a conversation, realizing that there are multiple decision makers in this process, and the consultant is just one of them. And everyone has to be on board with what we're trying to do, because if that occurs, then you start unlocking the key to being able to grow in the employer space. So my approach to a consultant or a broker was always about, what are your challenges? What are you trying to do for your employer, and how can I better support you? And more importantly, when it's successful, get out of the way and let them have the credit for bringing all of these pieces together, because it's a collaborative approach.
Yeah, and I think I could add that, if the consultant brokerage community is a mystery to you, it is vast. It's very much lines up with local geographies, and so there's regional brokers and national brokers, and so it is a lot to navigate for sure. The one thing that ties it all together, it's very much a relationship business, and so to understand what's the broker or consultant after, they're there to take care of their client. Their business is based on retaining often these relationships over many years. And so the employer's coming to them for advice to make sure that they're doing things in a fiscally responsible way, being innovative, whatever it might be. I think always starting with the intention of it being a collaborative process is the right way to go. I think there's still a lot of nuance to it in terms of doing direct primary care. I think there's really strong alignment on why primary care should be done better. Everything we've been hearing at the conference, I know everyone is on board with that, and you will get agreement from brokers and the employers, at the same time on those points. But they're also thinking about it as just like, are we duplicating spend, or could we be putting spend at a different place? Don't we already get primary care? Why do we need this extra primary care? So that becomes the consultative sales process, I would say. And often the employer is looking to their broker and consultant to kind of mediate that conversation.
Yeah.
I would add just one more thing to this too, is what I learned. When I started the practice, we were so far on the other end of the spectrum, which is I don't want to check a box anymore. I don't want to do reporting. I don't want anything to do with quality metrics. I don't want data. I am getting out of that, because that's what's creating this, moral issue of not wanting to practice medicine anymore. It had nothing to do with I hate taking care of patients. It had everything to do with I hate checking boxes that are irrelevant to me at the end of the day. What I've quickly learned in the company is that we have to speak the same language. If we're trying to move them on a spectrum from this end of it to that end of it, it doesn't happen very easily if you're trying to go from point A to point Z. There's several processes in the middle. One of those are being able to tell the story that is so valid in direct primary care, which is we are making a difference in the total cost of care, not primary care. This was a challenge that took me years to get people to understand that when you look at a large employer, 500, 1,000 lives, and they have a primary care spend of 3% of their total cost of care, or maybe 5% of their total cost of care, and my services are going to be 8%, the first question is, well, we're already paying for primary care and we're paying $100,000 and you want us to pay $200,000? This doesn't even make sense. So that conversation doesn't work by saying, well, we're just going to intuitively spend more time with patients and therefore we're going to work at the top of our license, provide better care, decrease hospitalizations, decrease 30-day readmissions, no more ER and urgent care visits that are unnecessary. You actually had to look at data. And this is where I think as a community for direct primary care, we have to get more sophisticated. We can't take the position of we don't want to participate. We have to, because we have to be able to compare what we're doing to the environment that we're all trying to get away from. And the way you're going to tell that story and the way that a consultant is going to participate in that conversation is understanding that the data actually justifies spending more money in primary care than what we currently are spending. So if you get an employer to increase their primary care spend for 5%, they'll have a 10 to 20% return of total cost of care, which actually pays for the 5% of primary care that you asked them to increase. But they won't do it because you said it will work. They do it because they can look at the data, they can look at claims, they can look at all of these trends. So we've done a really good job of looking at employers pre-implementation, post-implementation, year 1, year 2, year 3 of direct primary care, and creating these cohort analysis to really understand trend lines, data, cost of care, total cost of care, and the areas of impact that DPC has, which is not just ER and urgent care. There's some really easy picking fruit: ER, urgent care, labs, meds, advanced imaging. Okay, that's awesome. But we do a hell of a lot more than that. We decrease hospitalizations. We decrease specialty care. We actually improve 30-day readmissions because we manage our patients when they come out of the hospital. Our job is to get them out of the hospital because unfortunately they die in the hospital if they stay there too long. So having this relationship and workflow that gets people and how the money in the healthcare is spent, that's the impact of direct primary care. And we need to do a better job of telling the data story. And the larger you get and the more you get into an employer space in direct primary care, you have to tell the story. When an employer is writing $1 million check for your practice, it's not going to be good enough to say, well, we've got better access and better care and the people are happy. If you were writing $1 million check, you're going to want to know, what did you get? And more importantly, if you can show that you wrote $1 million check and we saved you 2 or 3, here's where you start changing the conversation. From a business perspective, most businesses run on 20% margins, 30% margins. So if I can save an employer $100,000, they would have had to bring in $1 million of revenue to put $200,000 in the bank. So when you change the conversation and go, yeah, we saved you $200,000, well, that's not a big number when they have, a $10 million spend. But if you put it in relation of like, well, you would have had to grow your business by $1 million in order to get the $200,000 I just gave you, it changes the conversation. The only way you can have that conversation is by looking at data, claims history, total cost of care, all of these little areas where like the pennies add up and the dollars add up. And that's the impact direct primary care has. And as we get more evolved as an industry and more sophisticated, that story has to be told differently. And we have to be, in my opinion, in the driver's position, helping steer these conversations, because we're doctors, it's our profession, and it's our responsibility to make sure that everybody's in alignment and we have a seat at the table for decisions that are being made that we have to react to. So, sorry, that's my spiel.
You bring up a really interesting point of capabilities that employers are interested in. And so for smaller practices, there's many of us that have got smaller practices, many of us would be interested in attracting some larger employers. What would be your recommendations or suggestions to us in terms of what services or capabilities to add in order to be able to attract those larger employers?
I could start. I think as I said before, employers are really on board about trying to improve primary care. So the desire to create kind of a care team approach with multiple services, so that may include things like behavioral health and pain management and musculoskeletal, whatever it might be. That true kind of care coordination and primary care model will really resonate. Every broker, client, employer has been a patient themselves, so they know that they can tell better care when they get it themselves. And I'm sure everyone's aware. It's just we're in a decade now of the explosion of like different digital health solutions. So it's also very confusing to employers that are trying to decide, do they need sort of specialized products? So I think there's a real value in sort of pulling it back to primary care that, with an extended appointment time, much of these other chronic condition management issues can get done by your primary care doctor or by some ancillary within the office. They're wide open for hearing that.
I think one of the things too that was really helpful for us is I've never told a direct primary care to somebody and they said, that's the dumbest thing I've ever heard. They've always said, how come I've never heard about it? And where can I get it? So that's not the conversation. What we also found on the employer side is that engagement is extraordinarily important. So you have to not just collect the money from the employer, you actually have to show your value. We're not in the business of healthcare, that's our profession. Really what we are is a service industry, no different than a hospitality company. So if you have a person that's writing you a check for $100,000 a year and they don't see the value in that cost, they're not going to keep you. So you have to provide value outside of just doing good primary care. One of the things that we know is that if a patient comes into the practice, whether you have a doctor or not, and you've had them for 20 years, 90% plus of you will never go back to see them because of the experience that you have inside of a direct primary care practice. So what you really need to do is get the employers on board and let them experience this. So give away your memberships. Go find the CEO, go find the HR person, go find the CFO, give them their memberships. tell their families to come see you, because believe it or not, the families will probably help make the decision for that HR person more than the HR person will. So get everybody involved and give them a 30-day trial or a 90-day trial. You'll do one of two things. You'll convert that company onto your platform, or you'll get a new member from that HR person or CFO, because they will not go back to their doctor. It's just the way that the practice works. So that's been a really, really good approach for us to help grow too.
We've got 1 minute left, and so this is what I was really curious to end in. I have made plenty of mistakes. I prefer to learn from other people's mistakes, and so tell me one mistake that you have made in your journey that you wish to impart to us so that we can learn from you and not make the same mistake.
Early on in the company, it's very hard to say no to revenue because you're trying to pay your bills. As we grew a little bit more, I made a mistake of not saying no to an employer. It wasn't sold properly. It wasn't communicated properly. We weren't involved in that process. It was delivered to us from a consultant. And when we signed the contract, I told my team this is probably not going to end very well. And sure enough, a year later, they pulled the contract, and it really put a black eye on us because in their mind, DPC was a failed solution and it didn't work. And so that's the mistake that I've learned is you have to learn to say no. You got to know what you do really well, and you have to be able to tell people we're not going to do that. And they actually probably want it more when you tell them no at the end of the day.
Yeah.
I think maybe listening more and not assuming a level of knowledge and making sure that you go in and really explain why you're a true believer about something and why it's so important is sometimes you can miss that other people are not at that level. And so you really have to build up that understanding and recognize that they have their own set of stakeholders that they're going to need to communicate to. So helping them learn the language and be able to talk to their peers.
Right. Well, thanks for your time today, and thank you for having us.